name is Dr. Aisha. My name is Dr. Aisha Sahib, and today my topic of discussion is dengue in pregnancy and management protocols. First of all, the background of dengue is that it is caused by flavivirus, which is an RNA virus, and it is the vector for the transmission of this virus is in Aedes aegyptis mosquito.
Aedes aegyptis.
Yes, Aedes aegyptis mosquito, which transmits it to the humans. Most of the areas in Pakistan are in dengue endemic, and the earlier detection is the key to proper management and the prevention of fatality in dengue. 40% of the world's population lives in the dengue prone zone, and according to WHO, 100 million infections occur every year, out of which 500,000 they end up in dengue hemorrhagic fever, and nearly 22,000 deaths occur due to this. The obstetrician is the first line of physical physician. So that it can be managed accordingly. The natural course of dengue illness, it flows from asymptomatic to mild fever, and then undifferentiated febrile disease, which can later become dengue fever. And if it is complicated, it can result into dengue hemorrhagic fever. The difference between dengue fever and dengue hemorrhagic fever is that plasma leakage occurs in dengue hemorrhagic fever, and it is absent in dengue fever. Due to plasma leakage, it can further end up into shock syndrome and further expanded dengue syndrome, which multiple organ failure occurs.
You're right. What you want to emphasize here is that some cases of dengue, they remain asymptomatic, silent.
Yes.
No, there are no symptoms. And then there can be mild fever also.
Yes, sir.
And then there can be an undifferentiated febrile illness. Like it can be like COVID presentation. There can be fever and body aches, etc. So that would be. But then dengue fever itself. So that is the spectrum through which the various presentations present. And therefore आपने 5 यहाँ पे वो लिखी हैं, लेकिन उससे 2 से पहले भी asymptomatic वाली है और एक mild fever वाली।
तो मैंने ऊपर आपको दिखाया ये यहाँ से asymptomatic mild fever।
ठीक, शाबाश।
Dengue viral fever can be presented as asymptomatic and symptomatic. Symptomatic can be undifferentiated fever, dengue and viral syndrome, or dengue fever, as I previously mentioned, and dengue fever can be with bleeding or without bleeding, and dengue hemorrhagic fever can be without shock, and it can be with shock, which is dengue shock syndrome, which means it can be compensated or decompensated. Then further, it can be expanded dengue syndrome, as I previously mentioned, that it involves multiple organs, and this can be fatal. Dengue can be divided into, after 2 weeks incubation period, it is divided into 3 phases: the febrile phase, the critical phase, and the recovery phase. The febrile phase, the symptoms are fever with headache, arthralgias, myalgias, and the tonic-quit test is positive. If the tonic-quit test is positive, it means that if we apply the BP cuff, like halfway between the systolic and the diastolic blood pressure for 5 minutes, and there are petechial hemorrhages on 1 square inch area, more than 10 petechial hemorrhages on 1 square inch area, then the tonic-quit test is positive. The potential complication in this febrile phase is dehydration, and the WBC count is low in most of the cases, but it can vary in pregnancy. I will discuss it further. The critical phase, in the critical phase, the fever starts subsiding, but warning signs appear. We can see that the fever is subsiding, and we might think, okay, now it is recovery. But the warning signs start appearing, which are shock, bleeding, multi-organ involvement, and this is when the plasma leakage occurs. Platelet count is low and hematocrit rises. Even though the platelet count is low, but still the hematocrit is rising because there is plasma leaking, and this occurs from the 3 to day 6. In the recovery phase, this also afebrile, and they can be volume overload because of the interventions we take, which will be discussed further. And the hematocrit, it starts stabilizing, the WBC count increasing, and platelets, they increase as well. Oh, this is not clear. In the acute febrile stage phase, there is high-grade fever, and this occurs from day 1 to 7 mostly, but 1 to 3 is most common. The facial flushing, skin erythema can be caused because of the petechial hemorrhages and the bleeding that can occur because of the low platelets. Conjunctival injection, body aches, myalgias, arthralgias. Retroorbital pain is one of the very important symptoms that the patient will present with, along with the fever. Headache, sore throat can also accompany. Anorexia, nausea, and vomiting are also alarming. Vomiting should also be considered as alarming in this case. Rash looks like measles sometimes, so this can be misdiagnosed as measles as well. On physical examination, there can be normal petechial or mucosal membrane bleeding. Liver might be enlarged and tender after a few days of fever. Tourniquet test, I've already told before, this can be positive. And the earliest thing that is noticeable that on CBC, that WBC count is low. We have a decrease, the leukopenia occurs. The critical phase, capillary leaking occurs when the fever starts subsiding, and significant plasma leakage occurs from the intravascular compartment to the extravascular compartment. This leads to shock, and uncompensated shock is the cause of death most of the cases. Hemorrhagic manifestations occur. Severe organ involvement may develop later, and liver, brain, heart can be involved. The warning signs of plasma leakage are persistent vomiting and severe abdominal pain. This can also be, the abdominal pain can be due to the ulcers, bleeding ulcers as well. There's increasing lethargy, but the patient remains mentally alert, and the liver size increases and becomes tender. The critical phase, if it progresses, it can result in shock and death. The signs of shock are tachypnea, cold extremities, rapid breathing, mottled skin, BP becomes unstable and non-recordable, tachycardia. This is like general signs of shock. Recovery phase, as the patient if the patient survives the critical phase for more than 24 to 48 hours, there is a gradual reabsorption of the extravascular compartment into the intravascular compartment, and the patient starts improving. The appetite returns, GI symptoms become normal. The hemodynamic status is also becomes it stabilizes, and but the problem in this WBC and platelets rise. But the problem in this case is that this can result in hypovolemia because of the fluids, the IV fluids we give in the treatment, as discussed further. And acute pulmonary edema can occur in the recovery phase, and that can be because of the fluid overload. The lab diagnosis is not essential for the clinical management because there is dengue. The fever in the time of endemic, if the pregnant woman is presenting to you with high-grade fever in the time of endemic with any 2 warning signs that are discussed before, this we should definitely consider it as dengue. And lab diagnosis, the lab results, they are considered later. The rapid NS1 test is the confirmatory test. And then the IgM antibodies are also detected after day 5. The details are here. NS1 antigen, this is usually diagnostic for the first 3 to 4 days. And after that, then the IgM antibodies, they can be detected from day 5 in the primary infection. And in after day 5, IgG antibodies, they also form. And in the secondary infection, the IgG antibodies, they might be detected earlier on day 3. This will differentiate between the primary infection and the secondary infection. And this can also be a prediction for dengue hemorrhagic fever, in which plasma leakage occurs. Real-time PCR is definitely the gold standard, but this test is expensive and we don't have, it's not very common. WBC count, decreased WBC count is also very much suggestive of dengue, but in pregnancies, leukopenia may not be a feature, and WBC might be normal or even high. But a decreasing trend in the WBC count, if we repeat the CBC later, can be an indication of dengue. Thrombocytopenia is another indication of dengue in which the platelet count is decreasing. It has a decreasing trend. Hematocrit could be normal or high in pregnancy. But as I mentioned before, that if a pregnant woman is presenting with fever with at least 2 signs and symptoms of warning symptoms, then we should definitely consider this as dengue and not wait for the tests. This dengue can be misdiagnosed in pregnant women because we have a wide range of differentials. I will just discuss in pregnancy. Abdominal pain can also occur in labor, placental abruption, uterine rupture, fibroid degeneration, urinary tract infection. So this can be, this is a differential for that. Shock, hemorrhage, embolism, postpartum sepsis can also occur in rape. This can be a differential as well. Respiratory distress can also occur in pulmonary embolism and pneumatic fluid embolism. Bleeding can be due to coagulation disorders, APH, due to placenta previa abruption or other causes. DIC due to the fetal demise, abruption and PPH can also be the cause of bleeding. Thrombocytopenia or leukopenia can be present in gestational thrombocytopenia or HELLP syndrome. Vomiting, which is one of the warning signs, may be taken as hyperemesis in pregnancy, so this can be misleading. Baseline tachycardia is also present in pregnant women, and low baseline BP is there, so this can mislead too. Challenges in monitoring and management are the failure to recognize plasma leakage and shock early will lead to decompensated shock and multi-organ failure. If the delivery becomes inevitable in the critical phase, then we should be very careful that blood should be cross-matched and blood products should be arranged accordingly. The trauma should be minimized. There should be minimal trauma that we should opt for the normal delivery as SVD as compared to the surgical if it is a possibility. And transfusion of platelets should not be done before too early. It should be initiated during the delivery or just near the delivery, because the half-life of platelets is short, like 6 hours, and after a few hours the bleeding can start again if delivery is not possible in that time. Fresh or whole blood or fresh packed cell transfusion should be administered as soon as possible if significant bleeding occurs. If blood loss can be quantified, it should be replaced immediately. And we should not wait for the blood loss to exceed 500 ml. And another important thing here is that we should not opt for the vaginal delivery if the platelet count is less than 50,000, and we should not opt for the cesarean section if the platelet count is less than 75. So the platelet count would you have 75,000?
नहीं, अगर cesarean section है तो वो तो अगर obstetrical reason के लिए आपने cesarean section करना है तो वो तो करना ही करना है.
जी सर, लेकिन वो उसको फिर मेंटेन करना है, उसका लाइक प्लेटलेट्स हमें मेंटेन करने हैं 75,000.
वो इस तरह से ये ना लगे कि अगर प्लेटलेट इतने हैं तो कुछ सिजेरियन सेक्शन नहीं करना, अगर जरूरत पड़ती है तो वो है तो उसको
मेगा यूनिट देके platelets should be at that level. This is the we should have the blood and blood products in hand so that it can be done. Oxytocin infusion should be given, sir, but I have a confusion over here. They have mentioned that misoprostol can be given, but in case of fever, if misoprostol is given, then the fever might raise.
हाँ, ठीक है, तो आप misoprostol को omit कर सकते हो because
but
it can cloud the picture.
Yeah,
that's what you mean, that because of shivering and temperature rise. But usually with misoprostol that happens for a short period of time.
Yes, but it can increase.
It can aggravate that. Yeah. Right, you're right in that. That's why mostly it is oxytocin infusion which is recommended for that.
Yes, sir.
And the labor has to be spontaneous. You don't induce until and unless it is.
Yes, sir. Well, I mentioned that we should delay the labor as far as possible if it can be done. Intramuscular injections should be avoided. Post-delivery newborns with mothers who had dengue just before or after delivery should be closely monitored because the vertical transmission is there, and we should see them, or we should observe them on those lines. Suspected dengue in pregnant women coming with fever, we should do the baseline on day 1, day 2 of fever, and the same WPC, and further fallen platelets should be seen from day 1 to day 2. There should be 4-hourly temperature charting, and pulse, BP should also be monitored. Urine output is very important because in case of shock, this can decrease. So the patient should be catheterized if we have admitted the patient. And capillary refill time should be monitored, intake output record, or like urine output here again. And labs, daily CBC should be done, and other investigations if necessary. A very important thing is that paracetamol is given in the treatment of pregnancy, and it's 500 to 650 6-hourly, but the total amount should not exceed 4 grams in 24 hours. But a very, very important thing is that NSAIDs should be avoided. They are absolutely contraindicated in dengue because there is already hemorrhage occurring, and sponging should be done for fever. We should hold aspirin if the patient is already taking aspirin due to some other reasons. Luprin, most of the people are on Luprin in pregnancy, so we should hold it immediately. And oral intake should be encouraged, but if the oral intake is not enough, then we should at least aim for 2.5 liters of fluid intake. But nausea, vomiting, if that is not the case, then IV fluids, they should be given. And if the urinary output is decreasing, or there is vomiting, lethargy, narrowing of pulse pressure, and delayed capillary pressure refill, then this is also alarming and should be notified immediately. The warning signs of capillary leak are to be looked very vigilantly, and abdominal pain or tenderness should be very vigilantly seen because that can be showing the internal bleeding or ulcer bleed. Rise in hematocrit if the baseline is not considered. Okay, so now this is if the dengue fever is present with the warning signs that I mentioned earlier, then the monitoring should be like this. Vitals should be monitored hourly. The patient should be catheterized here, like in group. This is group B, and the patient should be catheterized for monitoring for the urinary output monitoring. There should be intense fluid resuscitation, and normal saline is the fluid of choice over here. A bolus of 5 to 10 milliliter per kg per hour in the first 2 hours for 2 hours should be given, and followed by 3 to 5 ml per kg per hour as a maintenance dose. This is monitored by urinary output and pulse pressure, and we should avoid induction of labor or planned surgery in this case. So you're warning the sign, the thing you mentioned before.
Warning signs
तो कुछ पहले भी बता दिया जिसमें आ गया, लेकिन ये वाली चीज ये वापस ये वाले जिस तरह से है एब्डोमिनल पेन, और वो है जिसमें लग रहा है कि क्या लीकेज हो रही है ज्यादा, शिफ्टिंग ऑफ फ्लूइड फ्रॉम इंट्रावास्कुलर स्पेस टू एक्स्ट्रावास्कुलर स्पेस.
Now, if dengue fever is occurring with shock, this comes in group C, and the management varies. These patients need institutional management. अगर ICU setup में से shift कर देंगे for the patient को, timely fluid management with the parents of any warning signs should be started. Blood draw करेंगे for CBC and hematocrit status, और फिर cross match फौरन से होना चाहिए available, और LFTs भेज देंगे, electrolytes भेज देंगे, fluid bolus foreign दे देंगे, as I mentioned before, normal saline का 10 cc, but 10 cc per kg over 15 minutes हम देंगे. पहले वो 2 hours वाला था, अब 15 minutes में before transferring the patient to the ICU. और फिर the second bolus of 10 ml per kg for the next 1 hour, फिर 15 minutes में, then for the next 1 hour during transferring from the patient to this ICU. And then we should hand over all the reports and the fluid bolus details to the team over there. In convalescence phase, rise of WBC count followed by rise of platelet count, stabilization of hematocrit. This shows the convalescence stage. Now we should watch for fluid overload. This I have also mentioned before, that pulmonary edema might occur because we are giving so much fluid, and we should watch the patient closely for any cough, wheeze, tachypnea, or any signs of systolic or diastolic blood pressure increase. How can we discharge the patient? If the patient is afebrile for 24 hours without antipyretics, this is one thing: improve appetite, normal hematocrit or at baseline, and rising trends of WBC and platelets in the patient will be discharged. Very, very important points are no NSAIDs. And the option of fluid, it is the normal saline 0.9%. This is the best choice. And this later colloids can also be given only if 2 fluid boluses are given to the patient who is in shock, but plain dextrose solution is not used. Transfusion, we should be ready, and we should be prepared all the time. And prophylactic platelet transfusion is not recommended unless delivery is inevitable in 6 hours because of the platelet half-life. And so this is the thing I mentioned, that the platelet count should be more than 50,000 and 75,000 for operative delivery, 50,000 for SPD and 75,000 for operative. Clinically stable dengue with low platelet count and no platelet transfusion should be done, and there is no role of steroids or IV immunoglobulins or prophylactic antibiotics whatsoever in this case. Operative delivery and obstetric indications should be only for obstetric indications. We should avoid planned induction or delivery or cesarean section. Delivery should take place in a hospital where everything is like available, a skilled team. Tocolytic agents and the measures should be used to postpone the labor in the critical phase, maybe when the warning signs are there. This is a brief thing. I've already discussed this. So should I explain this again? It's a very good table. Sir, warning signs. If the warning signs are cardiac business, severe abdominal pain, tenderness, persistent vomiting, mucosal bleed, liver enlargement, clinically fluid accumulation, lethargy, restlessness, increased hematocrit growth. Okay, if there are no warning signs, the patient falls in group A. This should be managed as outpatient management. If there are warning signs available present, then the patient should be in group B for patients with warning signs of severe dengue. And this
since your topic is dengue in pregnancy, so all patients who are pregnant and they are suspected to have dengue fever, they should be admitted.
Yeah, they fall in group
their
B,
management is not on OPD basis.
Yes, and for patients with any severe cases, this plasma leakage occurs, or severe bleeding or severe organ involvement, they fall in group C. This is group B management. This may obtain baselines, monitor fluid vital signs, and this I've already discussed. This is a very nice table. But if the things are not improving, then group C, and this management of group C over here is I've discussed this. Maternal, fetal, and neonatal outcome in pregnant women. And dengue fever, pregnant miscarriage, the rate of miscarriage or loss of product of conception is less than 22 weeks. gestation is ranging from 3.8 to 16%. And dengue fever in pregnancy increases incidence of stillbirth from 4.7 to 13%. And preterm birth less than 37 weeks, the incidence is 3.1 to 26.6%, and low birth weight is 1 to 58%, like preterm. Vertical transmission does occur. That's why we should be very carefully monitoring the fetus. We should be monitoring the baby after delivery as well. And the fetal complications, they are meconium aspiration, oligohydramnios, and the fetus, the baby will get dengue as well. And if the maternal antibodies are not formed yet, and then it can be difficult for the baby, and the baby can present with dengue fever as well. Okay. The children are different, and they never shiver in fever or hypothermia. Maybe initial manifestations, neonates are unable to complain, so we should be more careful in them. Early recognition of dengue illness in neonates due to perinatal transmission deserves special attention. Onset of fever in newborn varies from 1 to 11 days after birth. Therefore, suspected neonates should be observed for 1 week for the evidence of vertical transmission. Clinical manifestations of vertically infected neonates vary from mild illness such as fever with petechial rash, thrombocytopenia, hepatomegaly, to rarely severe illness with pleural effusion, gastric bleeding, circulatory failure, massive intracellular hemorrhage. So उनकी भी लैब डायग्नोसिस फिर आ जाते हैं, उसमें वही ल्यूकोपीनिया है, फिर NS1 है, और फिर मैनेजमेंट उनकी से डिफरेंट होती है. इन यूनिट्स में 10 to plus 5% dextrose is recommended. For the rest of the management, it is referred to as different. Dengue fever in mother or neonate is not contraindication for breastfeeding. They can be breastfed. And infants should be monitored closely, and
right. Where did you get all this information from?
So GCP guidelines, and here is another paper.
GCP guidelines.
Sir, in my Pakistan, 21.
Or क्या?
Good clinical practice guidelines.
और कहाँ से?
एक और सर guidelines है सर, वो share कर दूँगी, वो कभी group में भी share होंगी.
All right. Now, my comments about this presentation is, number one, I didn't know about the topic till yesterday evening, but I'm told that this has been, this topic was selected on the request of many participants in this group. Anyway, but I compliment our resident for presenting it so well. She's accumulated relevant information from various sources, but primarily from the guidelines which were prepared by the dengue expert advisory group of Government of Punjab. That's a good document. You can download it from the net. It's a 90-page document, and she has very nicely summarized it. As a matter of fact, I don't really think that you have to go to that document, which is 90 pages, and it explains a lot of physiological changes in pregnancy, and then juxtaposing them with the changes which are how those are affected by dengue fever. So what I would suggest to you that you can go through that 90-page document quickly, and then get down to this presentation and make your own notes. It will take a couple of hours for you to make your own notes, but this summary of presentation and some of the infographics which have been shown, they are taken from CDC. That should be enough for most of the doctors who are practicing obstetrics to manage pregnancies. So you can align various slides and various aspects of this presentation and make your own individual notes. That would be my suggestion to all who are present at this forum, but go through that document. It's not necessarily that you have to go through the whole of 90 pages. I went through this in about 1 hour and looked at the relevant information, which is very nicely summarized here. I once again say that. So you make your own notes so that you can refer to them and manage the patients. The salient points she has mentioned already. She was a little quick to mention all those, but I would say that dengue is a potentially dangerous and fatal disease. But in pregnancy, the consequences are increased. So there is a greater danger of severity of the disease in pregnancy, and therefore we should not take it lightly. As the group's division into A, B, C was done, the group A is in whom it is mild and the patients can be treated on OPD basis, whereas in pregnancy, or if dengue takes place in a pregnant woman, that falls into group B, in which hospitalization is required, closer monitoring is required, the adverse effects can be for the mother as well as for the fetus. There can be vertical transmission, there is possibility of preterm birth, intrauterine growth restriction, and transmission of the virus to the baby for developing neonatal dengue, which would be obviously dangerous for the neonate as well. And then the peculiar changes, physiological changes which take place in pregnancy may mask some of the features of dengue. And therefore, one ought to be more careful in interpreting changes and more alert to various factors which take place. So far as lab investigation, one is that on physical examination, as I understand, one has to, the severity of the disease, what happens is that there may be ascites and there may be pleural effusion. Those have to be identified. Abdominal pain, vomiting, etc. Those are the symptoms which, and abdominal pain, vomiting, temperature, these are the symptoms that those have to be seen. Then investigations, CBC is important, but it is a problem which can affect most of the organs. It can affect liver, it can affect the kidneys. Therefore, liver function tests as well as renal function tests or urine output, as has been mentioned quite a few times, those are important parts of monitoring the patient. CBC, the effect is that there is the leukopenia and thrombocytopenia. So leukopenia is that it can come down to even 4 total leukocyte count, but it can also rise. And since there is fluid shift, there can be the hematocrit would rise. So those are the features upon which one would monitor the progress of the disease in the patient. The diagnostic tests, NS1. What is NS1?
This is the antigen which is present in.
Yeah, right. It's a non-structured protein, and this is an antigen which becomes positive early on in the disease. Immunoglobulin IgM is produced earlier, and IgG actually is produced in about 3 weeks time. But if it is present or it is detected in early part or in the first 3 to 4 days, that would mean that it's a repeat infection, and repeat infection is considered to be more dangerous than the first infection. And these are some of the points that I would want to highlight. Delivery, of course, because of the possibility of hemorrhage as a result of reduced platelets, So platelet transfusion would be required, in the indication for that be if platelets are below 50,000, or must be if they are below 30,000. And for obvious reasons, the trauma should be as little as possible. That is something which generally should be the aim, but in such patients that becomes even more important. Cesarean section would be done only in cases if it's obstetrically indicated, and it has to be covered with availability of fresh blood, and if required, platelet mega packs, mega units. And what else? If there are any questions.
One thing I did not mention. So there were complications here, further investigations are the key for ascites and ultrasound.
अल्ट्रासाउंड है या वो एक्सरे है,
वो फिर further investigation
वो इन्वेस्टिगेशन उस तरह से उसको उस तरह से करने के लिए। लेकिन ये जितनी इस प्रेजेंटेशन में टोटल 37 स्लाइड्स बनती, किसी ने कहा था कि जी इसको पीडीएफ में नहीं हो सकता, यू कैन कन्वर्ट दैट इनटू पीडीएफ। लो जी, प्रोफेसर रुबीना सुहेल is here, who has been a contributing author to these guidelines on this. तो मैडम आप अपने ख्यालात का इजहार फरमाइए।
आप लोगों ने बहुत सारी बातें कर दी होंगी। अस्सलाम वालेकुम एवरीवन। मेरे ख्यालात सिर्फ ये हैं कि one we have to understand that there are seasons in Pakistan when we are more prone to develop dengue, and one of the seasons is the rainy season. So you have to give precautions to the patient in terms of trying not to go outdoors early in the morning and at dusk and dawn. And also tell the patient not to have stagnant clean water in the house, and to avoid the areas where there's a possibility of getting the infection. The second thing is that we have to realize that dengue affects the baby in terms of prematurity, in terms of a miscarriage, in terms of IUGR, and in terms of pregnant death. So when a woman has dengue, then one needs to be careful about these things, and we need to tell the patient as well. Number three, I think that it is important to realize that during the critical phase of the disease, it is generally not a good time to deliver the patient. So one must be careful at that time, and sometimes labor might even be delayed so that the patient's condition can stabilize before you can deliver the baby. And I think that it's also important to understand that dengue fever in pregnancy is not an indication for an operative delivery. Operative delivery should only be done for obstetrical reasons. Regarding the disease itself, I think that 80% of the disease is actually self-limiting, so 80% of the patients might not even be diagnosed. The rest of the 20% who are going to be diagnosed, most of them are going to settle down only with monitoring and supportive treatment without a lot of intervention. So what we need to be on the lookout when a woman is suffering from dengue is the critical phase. And so we have to monitor the WBC count, we have to look for the enlargement of the liver, we have to keep an eye on the hematocrit and the platelet count of the patient. Previously, platelet transfusion was a norm in dengue, but it is almost out, and platelet transfusion will be needed only in exceptional situations. So in the critical phase of the disease, one has to be very careful about the fluids because it is a hypotensive state and fluid therapy is needed. But we must also remember that a lot of fluid that you are going to give, unless it is isotonic, it will move into the spaces and into the cavity, resulting in ascites and so on and so forth. So one has to monitor the patient carefully. And there are different types of rashes of dengue fever. So dengue can actually start with a rash and end with a rash. So in the recovery phase as well, there is a rash which is very typical of dengue fever, and that means that the recovery phase is starting. So in the recovery phase, the hematocrit stabilizes, WBC count come back to normal, and the platelet count starts coming up. So I think इतना काफी है या कुछ और
ठीक है, आपको से होगा। But this is a very good presentation. काफी अच्छी summary इसने बनाई है। वो सारी वो guidelines लेके CDC की infographics add किए हैं. And I have suggested to all participants who are having a look at that they should make their own individual notes from this so that they can understand that. So any questions?
Assalamu alaikum, sir. Assalamu alaikum, sir.
Walaikum assalam.
Ma'am, I have a question that here is written that there is a if there is a scar is continued, then stop it. What about the preeclampsia patient or the hypertensive patient on the S card? What should we do?
So Lopin has to be stopped. Lopin cannot be continued if the patient has got dengue pregnancy.
As a matter of fact, I think that in this endemic season, when we prescribe low dose aspirin to patients who, because low dose aspirin now has become kind of a routine prescription, not necessarily with those who are likely to develop preeclampsia or hypertensive disease of pregnancy, but even otherwise. So in this season, the patients must be warned that if they start feeling feverish, they start having body aches, etc., which might be the symptoms of beginning dengue, they must stop it immediately. So that is one precaution that can be advised to the patients in those whom low dose aspirin is being prescribed. Government of Punjab guidelines,
It is basically the DEAG guideline, DEAG. Government of Punjab की ही है.
Expert advisory group.
Any patient who has got hypertension, diabetes, or any other medical condition actually becomes a high risk patient in dengue fever, because it will add to the complication rate if there is dengue along with medical complications of pregnancy. So one has to be really very, very careful. एक फॉक्सी की भी गाइडलाइंस है वैसे डेंगू की, which are also rather simple actually. मैं वो ट्रेनिंग्स के ग्रुप पे शेयर
मैंने श्रीलंका की गाइडलाइंस भी देखी. श्रीलंका की गाइडलाइंस भी शॉर्ट है, बट दीज गाइडलाइंस जो हैं इसमें उसमें काफी सारे ऑब्स्टेट्रिशियन पार्टिसिपेंट्स हैं, तो उसमें उन्होंने ज्यादा जो एक्सप्लेन किया है दैट इज the physiological changes which take place in various systems like cardiovascular system, respiratory system during pregnancy. And then they have shown how those physiological changes are affected by changes of dengue fever. So there is that advantage that you will have a revision of physiological changes which take place during pregnancy. But so far as the relevant proportion of the dengue fever is concerned, that has been very well summarized in this presentation. SOGP hasn't had guidelines. If you got one guideline, that's good enough. Punjab government guideline is very comprehensive indeed. And CDC, these couple of infographics which have been shown in this presentation, they are also quite illustrative. So keep it comparatively simple. WHO guideline जानी है तो जाके you have to collect WHO guidelines for dengue, तो आपको पता चल जाएगा.
You don't need the WHO. देखो बात सुनो, जो ज़्यादा पढ़ते हैं ना वो फेल हो जाते हैं. Please ये ना करो. Don't look at all the guidelines. You are not supposed to do that. तुम्हें फिर PhD थोड़ी कराने लगे हैं dengue. So just look at the Punjab government guidelines and CDC. At the most, they are good enough for you.
मैंने अभी कहा कि भाई तुम इस पे 2 घंटे लगाओ, तो देख लो अपने नोट्स पर.
आपके लिए ये presentation बहुत है to pass the examination on dengue fever, and this is not the only topic of your exam. So please don't do this. Don't make yourself miserable. और एक बात मैं जो पे dengue में असल में बात खत्म हो गई है, मैंने एक बात कहनी है कि कल MRCG पार्ट 3 का रिजल्ट आया, बहुत सारे पाकिस्तानी लोग पास हुए उसके अंदर. So आप लोग जितने FCPS कर रहे हैं, make it your target to appear in the MRCG examination after this. So मैंने next task तुम लोगों को दे दिया. पढ़ाई शुरू करो, इसके बाद और MRCG की तरफ. हमारी 3 लड़कियां पास हो गई. महरीन, मावरा और संजीदा.
MRCG हो गई.
पार्ट 3
पार्ट 4 भी होता है.
3 के बाद इसका
3 मुश्किल होता है.
हां 3 लड़कियां पास.
अस्सलाम वालेकुम मैडम.
वालेकुम सलाम.
Madam, I have a question from diabetes. Can I ask?
जी जरूर पूछिए.
मैडम प्लीज ये कॉन्सेप्ट क्लियर कर दें कि ये जो लेबर में हम इन्फ्यूजन पंप देते हैं, मैडम ये इसके लिए क्या मैंडेटरी है कि हमने पेशेंट को एनपीओ करना है? मैडम ये मुझे प्लीज क्लियर कर दें।
देखो, मुझे सवाल का जवाब ही नहीं आता। मैं तुम्हें पहले ये बता दूं कि दो तरह के डायबिटीज हैं, एक है नॉन डायबिटिक और एक है जेस्टेशनल डायबिटीज। ठीक है, आपके पास आपके लेबर रूम के अंदर जो पेशेंट्स हैं 90% ऑफ देम आर एक्चुअली जेस्टेशनल डायबिटिक्स। जेस्टेशनल डायबिटिक को इन्फ्यूजन पंप की कोई जरूरत नहीं। जेस्टेशनल डायबिटीज जो है उसको आप सिर्फ लेबर रूम में मैनेज करते जाएं, उसमें वो रिस्क ही नहीं होता जो कि दूसरों में होता है। आपने सिर्फ कभी कभार डोज मिस करनी होती है, वरना उसके बगैर दे बिहेव ऑलराइट एंड यू डोंट हैव टू बी वरीड अबाउट दैट। द infusion pump is required only when the patient is a non diabetic, and in that as well आपको पेशेंट को हाइड्रेट करना है, तो एनपीओ करने की कोई वजह नहीं।
नंबर एक। नंबर दो चीज ये है, अब कंटिन्यूअस मॉनिटरिंग ग्लूकोज, कल ही मैंने देखा है कंटिन्यूअस ग्लूकोज मॉनिटरिंग इन प्रेग्नेंट वुमेन विद डायबिटीज। वो apparatuses यहाँ पे तो अभी अवेलेबल नहीं हुए, but if you go to Medscape you will come across that, and there is a small PowerPoint presentation as well available on that. I just downloaded this morning.
आप वो शेयर कर देंगे ग्रुप में?
मैं कर दूंगा। वो है continuous glucose monitoring।
जी मैडम। मैडम इसका मतलब हमने लेबर में 4 to 7 मिलीमोल्स रखना है, 1 आवरली मॉनिटरिंग करनी है, पेशेंट को एनपीओ नहीं करना।
नहीं, एनपीओ करने की क्यों जरूरत है?
ठीक है। और मैडम डेक्सट्रोज इन्फ्यूजन भी साथ पिलानी है ना?
एक बात मैंने कहनी है, वैसे भी आप लिक्विड ही दे रहे होते हैं। असली तौर पे लेबर के अंदर आपको सॉलिड्स देनी नहीं चाहिए फॉर एनी पेशेंट whether she is diabetic or not. So आप उसमें लिक्विड को क्यों मना करेंगे? पेशेंट को एनपीओ करने की कोई इंडिकेशन नहीं है।
और मैडम ये जो 10% डेक्सट्रोज वाटर है जो 83 ml पर आवर के हिसाब से देना है हमने जो इन्फ्यूजन पंप के साथ, उसके बारे में मैडम
जी फरमाएं।
मैडम ये जो डेक्सट्रोज वाटर दे रहे हैं 10% 83 ml पर आवर के अकॉर्डिंगली, वो हम कंटिन्यू रखें?
जी कंटिन्यू रखें उसको, बिल्कुल
ठीक है। ओके। और मैडम स्लाइडिंग स्केल अगर देना हो तो तब भी नहीं है एनपीयू करना?
दोबारा बोलिएगा, आवाज क्लियर नहीं है।
मैडम इसके अलावा दूसरी ऑप्शन होती है स्लाइडिंग स्केल, क्या आप लेबर में पेशेंट को स्लाइडिंग स्केल पे भी रख सकते हैं?
बिल्कुल।
मैडम उसमें पेशेंट को एनपीयू नहीं करना?
एनपीओ उसमें भी नहीं करना, एनपीओ करने की कोई इंडिकेशन नहीं है डायबिटीज।
जी
You can do it on sliding scale or you can do it otherwise, it's okay, does not matter.
ठीक है। और मैडम एक और क्वेश्चन पूछ रहे हैं मैडम, ये जो इंडोमेथासिन ड्रग है पॉलीहाइड्रोमनियास के लिए, इट इज ओनली रिजर्व्ड फॉर इडियोपैथिक पॉलीहाइड्रोमनियास ओनली?
अब तो जल्दी नहीं है, just contraindicated।
अब पहले दिया करते थे, ये आज से 25-30 साल पहले देना शुरू किया था, बट इसका कोई खास ऐसा रोल नहीं है कि आप इसको कंटिन्यू करेंगे।
नंबर 1 बेनिफिट लिमिटेड है, नंबर 2 इट रिजल्ट्स इन डिलेड क्लोजर ऑफ डक्टस आर्टरियोल सिस्टम, कोई ऐसा एडवांटेज नहीं है। अर्ली क्लोजर, सॉरी। सो इट इज नॉट रिकमेंडेड नाउअडेज। इसकी भी जरूरत है, लेकिन पाकिस्तान में आई डोंट सी एनीबॉडी गिविंग रिकमेंडेशन।
ठीक है।
और
अगर पॉलीहाइड्रोमनियास का पेशेंट आएगा तो मैडम फिर हम उसको एमनी रिडक्शन इस तरह की बातें मतलब एग्जाम में बताएंगे?
जी, अगर आएगा आप उसको रीअश्योर करेंगे, उसको सिम्प्टोमेटिक रिलीफ देंगे, उसकी ड्यूरेशन ऑफ प्रेगनेंसी को असेस करेंगे, उसको उसके रिस्क बताएंगे और उसको ये बताएंगे कि अगर एमनी रिडक्शन की तो वो दोबारा भी बन सकता है विद इन 48 to 72 आवर्स। सो एमनी रिडक्शन इज आल्सो ओनली हेल्पफुल इन सिलेक्टिव केसेस।
जी थैंक यू मैडम।
पॉलीहाइड्रोमनियास है क्यों? Is it because of diabetes or is it because of a congenital anomaly? That is what you have to try to find out, or it is idiopathic. ये देखना।
ठीक है जी जी थैंक यू।
अस्सलाम वालेकुम मैडम। मैडम एक क्वेश्चन था मैडम रिगार्डिंग पॉलीहाइड्रोमनियास। मैडम स्वेयर पॉली में मोड ऑफ डिलीवरी हम क्या रखेंगे? एमनी रिडक्शन करके हम नॉर्मल डिलीवर करा सकते हैं पेशेंट को?
यस एब्सोल्युटली यस। हाँ, बहुत अच्छा जवाब तुमने खुद ही दे दिया। एमनी रिडक्शन करें और इंडक्शन ऑफ लेबर करके डिलीवर करा दें।
जी ठीक है, थैंक यू मैडम।
इसमें वो स्टेबलाइजिंग इंडक्शन और वो जो
ओनली व्हेन देयर इज मैल प्रेजेंटेशन। अगर हाइपोथैलेमिक तो आपको स्टेबलाइजिंग इंडक्शन की जरूरत ही नहीं है।
ये कहते हैं आप बैल मुझे मार, फिर आपका वाइवा जो है बाकी चीजों से चल के तो वो स्टेबलाइजिंग इंडक्शन की तरफ चला जाएगा।
जी ओके। और सर कंट्रोल्ड ARM कर सकते हैं इसमें?
What is controlled ARM? There is nothing as controlled ARM. How can you do that? ये इंडिविजुअल डॉक्टरों की अपनी होती है।
नहीं, that will result in increased probability of abruption and complications for the baby. So try not to do that.
थैंक यू मैडम।
Thank you. Sir, आ चुके हैं प्रोफेसर आशिफ। सर अस्सलाम वालेकुम।
उनका माइक म्यूट है।
प्रोफेसर आशिफ को unmute करें।
हाँ, वो
वो करेंगे
वो कहीं दफा कर सकते हैं।
नहीं आप कर सकते हैं। आपका माइक म्यूटेड पे है, आपने अनम्यूट करना है।
यही लोग करते हैं, मैं शायद नहीं पता।
हेलो
हाँ जी,
हेलो, अस्सलाम वालेकुम।
वालेकुम अस्सलाम, क्या हाल है? तो
आप पूछ रहे हैं।
सर हाल ठीक ठाक है। आज हमने डेंगू पढ़ा है, डेंगू प्रेगनेंसी।
हाँ, मैं 15-20 मिनट से सुन रहा हूँ तुम लोग को।
अच्छा अच्छा।
मैं काफी आई एम वाइजर नाउ। नहीं और ये एक इम्तिहान के पॉइंट से बड़ा इम्पोर्टेंट लेक्चर है या क्लास थी, क्योंकि वेरी लाइकली कि चूंकि इस डेंगू कमिंग बैक अगेन एंड अगेन, तो जरूर एक टॉक स्टेशन पे आ जाएगा, जरूर आ जाएगा। आई कैन अश्योर यू, क्योंकि 5-6 सेट बने हैं टॉक्स के, तो उन 5-6 सेट का मतलब हो गया 80-90 सवाल बने हैं। तो 80-90 सवाल बनाना एक कार्य दारद है, और उसमें एग्जामिनर 10-20 के बाद मैं तो थक जाता। मैं फर्रुख कहना सी, मैं कहा यार तू बनाई जाओ, मैंने नहीं पता। तो ये एक्सरसाइज बनाने की भी बड़ी मुश्किल होती है, और उसमें अगर 80-90 सेशन बनाने हैं आपने, आई कैन तो ये डेंगू होगा वहां पे कहीं ना कहीं, और एक सेशन होगा।
particularly when there is a season of dengue, तो वो फिर हो ही जाता है।
तो इसलिए ये इम्पोर्टेंट है आज की क्लास। आप इसको अच्छी तरह रिहर्सल करके 10 मिनट में स्क्वीज कीजिए, जो फर्रुख साहब ने पढ़ाया है आपको। क्योंकि फर्रुख मैं पढ़ा इस बात पे जब से ये टॉक्स हुआ है, ये सब लड़कियों को कहता हूँ बाय द वॉच 10 मिनट में आपने सवाल खत्म करना है। ये रिहर्सल इनसे बार बार करवाता हूँ, और ताकि इम्तिहान में वो पूरी मैनेजमेंट डिलीवरी तक चली जाए बात। और रह गया कंट्रोल्ड ARM, इट डजंट एग्जिस्ट, इट नेवर एग्जिस्टेड। हमारे जमाने में एक S शेप मेटालिक कैथेटर होता था, उसका नाम मुझे भूल गया है।
वाटर कल्चर के लिए
हाइड वाटर ड्रेनेज करते थे हम। अब जब मैं हाउस सर्जन था उस वक्त हमारे उस डिपार्टमेंट में बड़ा रवाज था हाइड वाटर, और हाइड वाटर करते करते 90% में 4 वाटर ही होता था। रेयरली वो कहते थे पीछे जाके मेम्ब्रेन। सो देयर इज नथिंग लाइक कंट्रोल्ड ARM। जब आप रप्चर करते हैं मेम्ब्रेन, सडन गश ऑफ वाटर इज ऑलवेज देयर, उसको कोई कंट्रोल नहीं कह सकता। तो एमनियोसेंटेसिस जो
बहुत ही करना है तो वो एमनियोसेंटेसिस पर एब्डोमेन करके तो फिर उसको करने पे मेडिकल
जैसे मैं कह रहा हूँ, रुबीना ने जो बात की एब्डोमिनल एमनियोसेंटेसिस, वो कंट्रोल्ड है, वो कंट्रोल्ड है। तो उसमें जितना आप चाहें 200, 400, 500 सीसी निकाल सकते हैं, नीचे वाला कोई कंट्रोल नहीं।
ठीक है।
और तीसरी बात, इन्होंने आपसे बार बार पूछा लेबर में इंसुलिन कैसे देनी है, एनपीओ करना है नहीं करना। एक हफ्ते बाद पहली तारीख आ जानी है, उस दिन तेरा कुड़िए इम्तिहान है? यू आर नॉट। तो ये सवाल तुम पूछ रही हो, एनपीओ 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 3 दफा तुमने रुबीना से पूछा, शी वाज पोलाइट। तो तुम्हारी क्लैरिटी आज ये नहीं है कि लेबर में डायबिटिक पेशेंट को कैसे मैनेज कर रही हो तुम। आई एम नॉट टॉकिंग अबाउट एग्जामिनेशन। तुम कल को एफसीपीएस हो जाओगी, फिर फुल्ली सर्टिफाइड होगी, तो इस तरह ना करो सलूक अपने साथ।
ओके जी, ऑल द बेस्ट।
अच्छा जी।
Thank you.
हेलो हेलो।